Okay, good afternoon, everyone. Can everyone hear me? Can someone give me a sign that you can hear me? Okay, Dr. Martin is nodding. I see him nodding. All right. So let me get back to my screen here. So we are live on Facebook now and recording this webinar. So I would like to welcome you all to the third and final session of our virtual 2020 Breast Cancer Survivor Symposium. My name is Gina Chicatel. I am the Associate Director for Susan G. Komen, Northeast Ohio. Happy Halloween, by the way. It's easy to forget that today actually is Halloween because it's been such a weird year with all of the holidays, but it is in fact Halloween. Before we get started, I did want to run through some quick housekeeping items. I ask that all attendees please mute your phone lines when you're not talking. That way we can eliminate any background noise or distractions. But we want to make sure that if you have questions, you can ask those at any point during today's discussion by utilizing the chat box, which you should be able to find at the bottom of your screen. I will also be sharing some links to resources in the chat box, but feel free to type in your questions at any point. We will have time at the end, and I will read those to Dr. Martin so he can make sure that he addresses all of your questions. Again, we are recording this webinar as well as broadcasting live on Facebook. So if you know someone that could not attend due to a scheduling conflict, or if you want to go back and watch a specific part to get information again, you are free to do that. The recording will live on Komen Northeast Ohio's Facebook page. It will also be posted on our YouTube page, and we will have a link to the recording at komenneohio.org/Survivor Symposium, and that will be posted probably within the next 24 hours. And again, always available on Facebook and YouTube. So wanted to go over quickly some resources that Komen has available specifically on managing long-term side effects of breast cancer treatments. And I'm not going to spend too much time on this because it is all online, but we have a series called the Questions to Ask Your Doctor. They're printable sheets that you can print out, normally two-sided, with specific questions to ask your healthcare provider about the different long-term side effects. You can see here I have the photo for the lymphedema Q&A sheet, but we also have a bunch of topics like chemotherapy, radiation, and those side effects. And I'm going to share with you now a different screen if I can find it on here. Where are we? Not showing. Here. Hang on one second as I figure out all of this technology. Where did it go? That is the wrong link. All right. I'll show you at the end because for some reason or another, the window that I had open has closed. So we'll go back here. I apologize for the technical difficulties, but I will show you that webpage at the end once Dr. Martin has finished talking. So with that, I would like to go ahead and introduce our speaker for today, Dr. James Martin. He is, let me move this panel here. He's a medical oncologist at the University Hospital Seidman Cancer Center and an assistant professor in solid tumor oncology at Case Western Reserve University School of Medicine. He is board certified in internal medicine, hematology, and medical oncology, and is primarily focused on breast cancer oncology. So we're very happy to have him here today. He came to UH Seidman from Fox Chase Cancer Center in Philadelphia, where he was on staff at the Fox Chase Temple University Hospital's bone marrow transplant program and served as an assistant professor in the Department of Hematology and Oncology. He also served as residency site director for the bone marrow transplant program. Dr. Martin earned his Bachelor of Arts degree in chemistry from Ohio State. Go Bucks, I know there's a big game on today. He completed his residency in internal medicine at Rhode Island Hospital, Brown University in Providence, Rhode Island. And he completed his fellowship in hematology oncology at Fox Chase Cancer Center. Dr. Martin is very active in research and has served as an investigator on several studies in the areas of breast cancer, bone marrow transplant, and other hematology and oncology topics. And he has authored articles in various medical journals and has presented at national conferences and meetings. So with that, I would like to turn everything over to Dr. Martin.
Hi, everybody. Can you hear me?
Yes.
Good. So thank you, Gina, and thank you to Susan Komen Foundation for allowing me to come chat with you all today. Like Gina's nice introduction said, I'm James Martin. Please call me Jimmy. It's what I'm known as, Northeast Ohio. I'm a native Ohioan. I'm new to university hospitals. I just started here on September 1st. So it's nice to be back in Northeast Ohio. I grew up in Ravenna. So let me try to share my screen. Let's see. Let's see. One second. Okay, can you all see my screen? Did that pop up? Okay, perfect. Yes. Okay, good, thank you. All right. So today, as Gina mentioned, we'll be talking about the long-term side effects of breast cancer treatment and their management. An outline for what we'll talk about today. So I'll do a brief breast cancer overview and the state in the, of this cancer in the United States. An overview of the common systemic therapies used, including chemotherapy and other targeted therapies. We'll talk about some common toxicities that can be encountered with traditional chemotherapy, as well as toxicities of these newer targeted therapies, such as monoclonal antibodies and immunotherapy. We'll talk about a big side effect that can be experienced by breast cancer survivors, which is chemotherapy-induced peripheral neuropathy. We'll talk about cancer-related cognitive impairment, or also known as chemobrain. We'll talk about lymphedema, prevention and management, and then we'll talk about how the state of oncology is dealing with reporting toxicities and where it's moving to a more patient-centered approach, which I think is important. So, a brief overview of breast cancer. So as you may know, it's the most common malignancy among women in the United States. And despite very good, very important advances within the field over the past 15 to 20 years, it's still the second leading cause of cancer death among women in the United States. The lifetime risk for women is about 1 out of every 8 women will be diagnosed with breast cancer. It is seen in men at a much less incidence, and that's about 1 out of every 800 for men. As you can see here, let's see, well, let me use my mouse. It won't. So the bottom left graph basically shows kind of the age ranges for new cases of breast cancer in the United States. And then the graph on the bottom right shows that while the death rate from breast cancer has been slowly declining over the years, which is good, the rate of new breast cancers are going up. Breast cancers are classified as one of several pathologic subtypes, and that's based on what the pathologist sees, the cell of origin. You have ductal carcinoma in situ, or DCIS, which is considered a breast cancer. It is considered a malignancy, but a non-invasive malignancy. You have infiltrating ductal carcinoma, also called invasive ductal carcinoma, which is the most common pathologic subtype of breast cancer. Then you have invasive lobular carcinoma, which is about 15% of all breast cancers. And then you have some less common subtypes such as mucinous carcinoma, metaplastic carcinoma, etc. Staging, like most solid tumors, is basically graded 0 through 4, and anatomically it matters the tumor size, whether there's node involvement and what nodes are involved, and then whether there's metastatic sites elsewhere in the body. Nowadays, the 8th edition of the AJCC staging system, it actually uses some prognostic factors in determining stage. That changed about 2 years ago. And those prognostic factors that we know are important are grade of the breast cancer. So those are graded 1 through 3, 3 being the most kind of abnormal looking cells, lots of cell division. Grade 1 basically means that it looks very similar to normal breast cells, but are known to be malignant. We look at ER or PR or estrogen receptor and progesterone receptor. We look at HER2 expression. And then nowadays we also look at genomic testing. You may have heard of assays like Oncotype or MammaPrint, EndoPredict, to determine how the prognosis of every person with breast cancer. So what systemic treatment a person receives is decided by several factors, including the clinical stage, the receptor status is very important, patient wishes, we try to take that into account, presence of other medical issues that may preclude certain treatments, recurrence risk, which can be defined by some genomic testing, and other entities to determine treatment. So let's talk about some of the common systemic therapies that we use for breast cancer in the United States. The top 2 there are the most common types of chemotherapies that are used. So anthracyclines and taxanes. Anthracyclines, the most common in the United States is doxorubicin. You may see some epirubicin here and there. Doxorubicin and all anthracyclines are red. You may have heard it referred to as the red devil colloquially. A picture of it on the side there. Taxanes, 2 are commonly used for breast cancer in the United States. Paclitaxel, also known as Taxol, and then docetaxel, which is Taxotere. Capecitabine is used both in the metastatic setting as well as the early stage setting. Carboplatin is sometimes incorporated into various treatment regimens, cyclophosphamide or Cytoxin. Monoclonal antibodies, so that is a manufactured protein that targets a particular cell protein, the most common being trastuzumab or Herceptin, or Perjeta is pertuzumab. There are antibody drug conjugates nowadays that essentially have a targeted protein linked to a chemotherapeutic agent. The most common ones around are TDM1 and a brand new one called famtrastuzumab deruxtecan, or Enhertu. Both of those are used for HER2 positive breast cancers. And then nowadays we've been trying to incorporate some of the immunotherapies that essentially rev up or take the brakes off the immune system in order to fight cancer. And the 2 that are you'll commonly see for breast cancer are atezolizumab and pembrolizumab. Let's see if I can. So common therapeutic regimens. So we often use a combination of different drugs to achieve the goal that we want to achieve. Oncologists are simple people, and every regimen is essentially just an acronym of the drugs that are made up as part of that regimen. So common ones that you may see are ACT, which is doxorubicin, Cytoxin, and Taxol or paclitaxel. TC, which is Taxotere or docetaxel, and Cytoxin. Then you have the HER2 positive regimens, TCHP, ACTHP, PCB is paclitaxel and carboplatin, and then Taxol and Herceptin. Sometimes your oncologist may suggest if you've gotten chemotherapy in the pre-surgery or neoadjuvant setting, you may get some chemotherapy or some treatment in the adjuvant or post-surgery setting. Common ones that we use would be capecitabine or TDM1. And then for advanced or metastatic disease, we use single agent chemotherapies, taxanes, anthracyclines, eribulin, capecitabine. There are many options. For hormone positive breast cancers, we often try to extend endocrine therapies or anti-estrogen therapies as long as possible. And then one of the big kind of revolutions within breast cancer have been the targeted therapies that have come out over the past several years, such as CDK4/6 inhibitors, palbociclib, abemaciclib, ribociclib, PI3 kinase inhibitors, alpelisib, mTOR inhibitors, everolimus, and then various HER2 targeted therapies. So I shouldn't say common, so side effects that we worry about are traditional chemotherapy agents. Some of these are common and some of these are rare. So myelosuppression, so it can lower your blood counts. Organ damage, kidney, liver, lung dysfunction is possible. Peripheral neuropathy is a very common side effect from certain chemotherapies, and we will delve further into that today. Heart failure, particularly with doxorubicin or adriamycin, is a rare side effect, but it's something that we certainly worry about. Leukemia risk down the road is also associated with anthracyclines like doxorubicin, as well as Cytoxin. Cognitive dysfunction or chemobrain, which we will also talk about. Fatigue is essentially universal with some of these chemotherapy drugs. Skin toxicity, rash, nausea and vomiting. I think fortunately over the past 10, 15 years, we've gotten much better at preventing nausea, but it still remains a big problem for patients. Diarrhea or constipation, edema or fluid retention, and then hair loss for some chemotherapies is pretty universal as well. So for the monoclonal antibodies, the antibody drug conjugates, and the immunotherapies, I think we wanted to believe that these would be without significant side effects, unlike chemotherapy, but that we know is not true. You know, we still have to worry about heart failure, particularly with trastuzumab or Herceptin, diarrhea, colitis. The immunotherapies cause a very interesting set of side effects. They cause essentially autoimmune problems, colitis, pneumonitis, dermatitis. Peripheral neuropathy can still be an issue with some of these more targeted therapies, particularly TDM1 and one of the new drugs for triple negative advanced breast cancer, sacituzumab. Pneumonitis, myelosuppression, it can still lower your blood counts. GI toxicity is still very common, and of course, fatigue. So let's delve a little bit further into chemotherapy-induced peripheral neuropathy. So this peripheral neuropathy, it's a relatively common long-term side effect among breast cancer survivors, particularly due to the high usage of taxanes within the breast cancer treatment realm, as well as carboplatin. And this can lead to very long-term significant morbidity for our patients. Often it is a sensory deficit, so numbness or tingling, pain, but motor and autonomic neuropathies have also been seen. Rates of chemotherapy-induced peripheral neuropathy among breast cancer survivors, there's a big range reported, and it's anywhere between 20 and 90%, depending on what agent you're looking at. I tend to tell people it's about a 50 to 60% rate of peripheral neuropathy, especially among the taxane chemotherapies, paclitaxel and docetaxel. But as you see, it can be a significant problem. It's commonly associated, like I said, taxanes, carboplatin, and some of the antibody drug conjugates. Dosing is a very important factor here. And we know that sometimes how we dose the taxane or dose the drug, it can have higher rates of neuropathy. For example, paclitaxel or Taxol is a very common drug that we use here, either before surgery or after surgery. The weekly dosing tends to have lower rates of neuropathy than what we call the dose-dense version, which is a higher dose every 2 weeks. It can also be given every 3 weeks at an even higher dose. So the mechanisms for peripheral neuropathy are still a little unclear. We think that it's due to what we call microtubule dysfunction for the taxanes. Microtubules are important cellular structures for protein transport, and damage to the microtubules can affect peripheral nerves. And then we think that some of the chemotherapy, such as carboplatin, may cause just direct cell damage. Risk factors for peripheral neuropathy include age, a cumulative drug dose. This is important, particularly for patients with advanced breast cancer, as you would generally continue a drug as long as it's working and as long as it's tolerated. Higher body mass index is associated with peripheral neuropathy. Pre-existing diabetes can increase your risk for neuropathy. And then time from chemotherapy. So in general, we think that as your chemotherapy regimen ends and time goes on, the rates of neuropathy do go down. So let's talk about prevention. So aside from dosing modification, there are no formal recommended prevention measures endorsed by the American Society of Clinical Oncology, or ASCO, or NCCN, the National Comprehensive Cancer Network. This is an active area of study because it's much easier to prevent something than it is to treat it. But currently there's no formal recommendations. The most promising, in my opinion, area in prevention is cryotherapy or cold therapy. Now, the limited data that are out there are mixed right now, where some small studies have shown benefit and others have not. The theory behind cryotherapy is that the cold restricts blood flow, causes blood vessels to constrict, and then reduces the amount of chemotherapy delivered to a particular area. You may have heard of cold caps nowadays for prevention of hair loss. It's a similar kind of mechanism, or thought to be a similar mechanism. There was the largest trial for cryotherapy that's been published has had 180 patients that could be receiving paclitaxel, docetaxel, or carboplatin. And the usage of cryotherapy gloves had less self-reported neuropathy symptoms, but not overall neuropathy scores on these validated questionnaires. So that's where the data is the example of where the data is mixed. I still think it's important because if the patient is reporting less neuropathy, maybe our objective questionnaires are not catching it. So I still think it's important. Other small trials, like I said, have supported some benefit, and then others have no benefit at all compared to placebo. Tolerance can be an issue with these. Cold is very uncomfortable. And if you recall, if any of you out there have received, Taxol or paclitaxel, it's a long infusion in general, and sitting with your hands in very cold gloves can be it's very limiting. Combination of cryotherapy or cold therapy with compression therapy is also currently being studied. There's a big trial in the US. Compression therapy, just like it sounds, is things that help also constrict blood flow to a certain area. And then essentially more data is needed before formal endorsement. I've had several patients attempt to use these cold gloves, and I don't discourage it. But it can be uncomfortable, the cold. Other preventative measures for peripheral neuropathy. So there are some that look promising, have some small studies that maybe show some benefit. There have been some data to suggest that an exercise regimen a few times a week while undergoing chemotherapy actually leads to kind of less reported peripheral neuropathy. Acupuncture. There's an agent called ganglioside monosialic acid, or GM1. There was a Chinese study that essentially showed, this is an IV medication that patients who received this while undergoing chemotherapy did report less neuropathy compared to those who didn't. Vitamin E is also being studied. Agents that the data doesn't look good and that we do not recommend are acetyl L-carnitine, gabapentin and pregabalin, or Neurontin and Lyrica, are sometimes used for the treatment of neuropathy, but prevention, it doesn't seem like they're panning out. Amifostine, metformin, calcium and magnesium, and vitamin B. Vitamin B6 was promising for a while. There were some kind of reports of efficacy, but ultimately it's very conflicted. And essentially right now, no formal endorsement by either ASCO or NCCN. So if peripheral neuropathy develops while on treatment, the most important thing is dose delay or reduction. So this is where I urge the patients that I take care of to call me, let me know if they're starting to experience neuropathy, because we have to decide kind of together on, how bad is it, and if it warrants kind of a dose reduction or a potential delay of treatment. The only kind of formally endorsed medication for peripheral neuropathy treatment brought on by chemotherapy is duloxetine or Cymbalta. There are kind of larger randomized data to support improvement in patient-reported pain scores, functional scores, quality of life scores, and numbness and tingling, which is actually the improvement, strangely, was seen mostly in the feet, but not really the hands. The effect of duloxetine seems to be more pronounced for patients who are receiving oxaliplatin rather than the taxanes, paclitaxel and docetaxel. This particular study that put duloxetine on the market wasn't just for breast cancer patients. It had kind of all comers who were receiving these agents. There's another drug, venlafaxine, also called Effexor, that appears to have some benefits, but maybe not as pronounced as duloxetine. And the thing that we try to, when we're treating neuropathy, is that if it's a pain and tingling sensation, the chances of that responding to treatment are much better than a numbness. There aren't many things we can do to counteract lack of sensation or numbness. A few very promising entities for peripheral neuropathy treatment. So exercise. So I mentioned that maybe there's some data for prevention of neuropathy, but they have looked at exercise if neuropathy is already developed. That includes endurance training and strength training. There may be some benefit of at least reported symptoms for peripheral neuropathy, and this is an area of active study. Acupuncture is one of the surprising things that have come out over the past couple years. A lot of data has been published on the benefits for peripheral neuropathy treatment. So what I have there on the side is there was a trial where patients with neuropathy were basically randomized to one of two groups. The first group, or group A, received 8 weeks of acupuncture, and then the group B received just kind of usual supportive care. And then after 8 weeks, they flipped. So the top graph there is the first really 8 weeks. So as you can see, at least reported neuropathy symptoms based on this PNQ sensory score, which was a questionnaire, seemed to benefit those who received acupuncture. And then the bottom graph, or graph B, is after the crossover period where the two groups switched. So as you can see there with the top line, those who were in the initial acupuncture group, the benefit seemed to fade over time. And then those who were in supportive care and then started acupuncture seemed to have some degree of benefit. So, there are ongoing trials for acupuncture, but I do tell patients that if they can find a place that does it at, at a reasonable price, I think it may be a reasonable thing to try, because there's not much downside to it and we don't have a lot of other good options. Scrambler therapy. It's a device that delivers electrocutaneous stimulation to the skin. You use it in the areas where people have neuropathic symptoms. Some centers already have this and have been using it, and then there are active trials underway. This also has some promising kind of early data to it. So treatment continued. So other kind of entities that we can try. So gabapentin or Neurontin, pregabalin or Lyrica. The data don't seem as promising for chemotherapy-induced peripheral neuropathy as it does for diabetes or other entity-related neuropathy, but it is worth a try if somebody tries duloxetine or venlafaxine without much benefit. You'll see some docs prescribing tricyclic antidepressants, the most common being amitriptyline. There's also nortriptyline. Some patients do derive some benefit, although it hasn't been proven, at least in a trial. Glutamine has been looked at vincristine-induced neuropathy. So vincristine is another chemotherapy that we use for some leukemias and some other types of tumors, not really used in breast cancer, but there was, it appeared to be some benefit. There are active trials going on. And then kind of some low side effect potential treatments or topical therapies, so topical menthol or topical capsaicin. Some patients appear to report some benefit from that, at least in those that I know that have tried it. The most important thing, take-home point for this is that this is a very or potentially debilitating and bothersome side effect for breast cancer survivors, and a lot more work needs to be done because as you can tell, there aren't many kind of endorsed treatments for this. So let's talk about chemobrain for a little bit. So chemobrain, or cancer-related cognitive impairment, basically problems with memory, executive function, processing speed, attention. Patients tell me that they feel like they're in a fog, they're forgetting things. It can be associated with just the disease itself, undergoing surgery, chemotherapy, radiation therapy, hormone therapy, and immunotherapy. So it's not just related to somebody who's getting active chemotherapy. This is very poorly understood. It's likely multifactorial. You know, when you think of, for those of you who may have received chemotherapy, you go in, you get several pre-medications. All of those can have side effects. You get the chemotherapy itself, it causes fatigue. So there's probably a lot of things that cause this cognitive dysfunction. When you look at, there was one study of several hundred breast cancer patients, and they were compared to patients without a cancer diagnosis, not undergoing chemotherapy. And they used this, one of the kind of patient-reported tools or kind of validated tools for looking at cognitive dysfunction is this FACT-COG questionnaire. And up to 45% of the breast cancer patients who underwent chemotherapy reported some degree of cognitive dysfunction versus only 10% of the control group. And like I said, they didn't have a cancer diagnosis. And then at 6 months of follow-up, nearly 40% still did report some degree of dysfunction as compared to pre-chemotherapy. So data from the TAILOR-X trial confirmed that it's not just chemotherapy that causes this dysfunction. So some of you may know about the TAILOR-X trial. It's one of the biggest breast cancer trials that's ever been kind of undertaken. And what it did was it really got oncotype, or that genomic testing, on the map. And essentially patients, you know, every patient received an oncotype test, and those that were considered intermediate risk for recurrence were randomized to either receive chemotherapy followed by endocrine therapy or just go straight to endocrine therapy. And as you can see with the graph on the bottom left, so the red line are those who were randomized to chemotherapy. Their cognitive function, as you can see, drastic drop reported with the start of chemotherapy that eventually improves a little over time and then starts to decline. Those who received the endocrine therapy or randomized to just no chemotherapy, just endocrine therapy, as you can see, the blue line also does decrease with time. So this is validation for women who have been reporting ongoing cognitive dysfunction or the start of cognitive dysfunction when they're on endocrine therapy alone. I feel like they were probably told before in the past that endocrine therapy doesn't cause chemobrain, but I think that this is good validation that, you know, it's not just chemotherapy that causes this problem. As the cause of it is largely unclear, it is hard to identify potential treatments or interventions. We suggest eliminating potential confounding medications. Like I'd mentioned before, this is very hard to do. People get a lot of different pre-medications, including steroids, anti-nausea medications, anti-anxiety medications, things to help prevent reactions like Benadryl. All of those things can certainly impact somebody's cognitive function. Increasing physical activity, again, has been potentially shown to improve at least what they call processing speed or answering speed, if done kind of near the time of the cancer diagnosis. Cognitive training was studied within 82 breast cancer survivors with some improvement in speed of processing and memory in memory overall versus if patients in the control group. And this importantly was associated with improved quality of life scores, lower distress scores, as well as obviously the cognitive functioning benefits. Currently, there aren't any, drugs approved for, help with chemobrain or CRCI. Modafinil is a CNS stimulant that's currently approved for shift work, like sleep disorder, kind of multiple sclerosis related fatigue, and in a small study of breast cancer survivors that had high rates of ongoing fatigue, they received this drug and there seemed to be some improvement in memory speed, attention. Very small study, not formally recommended and not approved for this indication, but there seems to be some signal there. The NCCN recommends kind of memory aids, organizational strategies, routine physical activity, mindfulness activities such as meditation and yoga, and then limiting alcohol and other kind of cognition altering agents. But other than that, there's not much out there for this kind of cognitive dysfunction. Lymphedema. So many of you are very familiar with lymphedema. So it's a collection of the lymphatic fluid, which is this protein-rich fluid within the tissues due to disruption of the normal lymphatic flow. And that disruption can either be by surgery, radiation, the primary tumor, anything like that. As the picture shows, primary lymphatic drainage of the breast usually goes to what we call the axillary lymph nodes, or lymph nodes that are under the arm, but internal mammary nodes on the left there help drain the breast, and supraclavicular nodes kind of more near the neck bone as well. It is a major cause of potential morbidity for breast cancer patients. It can be a very bothersome side effect, and it can be hard to treat. Risk factors include disruption of the axillary lymph nodes, such as with an axillary lymph node dissection, just having an invasive cancer diagnosis versus a non-invasive tumor. Undergoing radiation after surgery increases somebody's risk, post-operative infection, and then obesity. Axillary lymph node dissection. So that is a type of lymph node surgery that some of the breast surgeons may have to do based on your level of lymph node involvement. That carries around a 20 to 40% risk of lymphedema, compared to if the patient can get away with just a sentinel lymph node biopsy, which only has about a 5% risk of lymphedema. So with lymphedema, the most important thing is prevention. We try to avoid an axillary lymph node dissection at all costs. That is why some of you may have received chemotherapy before surgery. Sometimes we can make cancer disappear from the axillary lymph nodes, which would potentially allow for a less aggressive surgery. Not all the time, and it does depend on what type of breast cancer one may have, but can this kind of big axillary dissection be avoided? Very prompt treatment of post-operative infection is important, because having an active infection within the breast or the axilla is associated with development of lymphedema. It's important for patients to take limb measurements at home, kind of take a mental note of how that effective extremity is doing, elevating the extremity. Some people use compression sleeves, which can be helpful. Physical therapy appears to be safe and effective after axillary lymph node dissection and has been shown to decrease the rates of lymphedema. If lymphedema develops and is significant, specialized physical therapists can do manual lymphatic drainage or decongestive therapy, which is a little bit more intensive for these more severe cases. And the last part of the talk today is reporting side effects of treatment. As you all may not be surprised about this, but there are actually a lot of data to suggest that healthcare providers underestimate toxicity or symptom intensity for patients undergoing cancer treatment. There was one particular study that showed that for moderate and severe symptoms, which included pain, fatigue, weakness, anorexia, nausea, diarrhea, were essentially all reported less by the providers compared to if the patient was asked. Underestimation occurred by about 10% of the providers. And how do we counteract that? So patient-reported outcome measures, or PROs, are becoming very important and very common in clinical trials and practice. And I think that this is the way that the field is going in terms of toxicity assessment. And it's important. So patient-reported outcomes. There was a large study by Sloan Kettering in New York City that used patient-reported outcomes in patients with metastatic cancer, and they were randomized to either receive routine care or fill out this web-based kind of toxicity questionnaire. And those patients that actually were able to fill out this questionnaire, it showed better quality of life measures. It actually decreased the number of hospital admissions, and it actually increased the time that the patient could remain on chemotherapy. Essentially, what this questionnaire did was if a certain score was reached on the questionnaire, a nurse from the treatment team was notified, and it allowed the treatment team to deal with the side effect sooner rather than just waiting for the patient to come in for their routine visit or call. An updated analysis from this study from New York actually showed that when patient-reported outcome measures were used, on average, the patients lived longer. And that makes sense. They were able to deal with whatever the problem was quicker than potentially the other control group. So we really need to do more work in incorporating these patient-reported outcome measures into kind of routine clinical practice in order to catch toxicities earlier. My takeaway from this is please notify your providers, if you're having a particular side effect, because often something can be done about it. So conclusions for today. So breast cancer is a common malignancy in the United States. We have made significant progress in the treatment and outcome of patients that have been diagnosed with a breast cancer, but not much, as I would say, a lesser degree of progress has been made in dealing with the toxicities from that treatment. And that is even with these new targeted therapies or immune therapies. Proactive management of peripheral neuropathy is absolutely essential. Chemo brain or cognitive impairment is poorly understood and is seen with other therapies other than traditional chemotherapy, and that includes endocrine therapies. Lymphedema prevention is vital, as well as early management. Don't let it get too bad. And patient-reported outcome measures are becoming increasingly important. So please, please, please talk to your providers and let them know how you're feeling. And with that, I can take any questions. I know some of you have sent questions into Gina, so thank you very much.
Yeah, so we have a few questions coming from one of our participants named Kim, who is here right now. Hi, Kim. So I'm going to ask these one at a time. And forgive me, I am not a medical professional, so I may butcher some of these medication names or some of the treatments. So I apologize in advance for that. But she's asking, is bronchiolitis a side effect of breast radiation? She is 6 years out of treatment, or 6 years after her treatment. She began having periodic episodes of spontaneous hemolysis, lots of imaging with eventual immobilization, which helped for about 2 years. And now the hemolysis is back with a diagnosis of bronchiolitis And she's wondering if this is a long-term side effect of her cancer treatment or if it's unrelated. And she threw in that she is a non-smoker and she's not exposed to secondhand smoke.
Okay, good. Thank you, Kim, for that question. So bronchiectasis is essentially scarring and kind of impliable airways. And it can be associated with radiation therapy for breast cancer and other malignancies. I think the radiation oncologists have gotten much better compared to 20 years ago at targeting a specific area to radiate, but we still come up with complications, whether it's cardiac complications, lung complications, depending on where the tumor exactly was in the breast or underneath the arm. So it certainly can be associated with radiation treatment. Often it will improve a little bit with time, but not always. So I hope that you're seeing a pulmonologist for help with management. There are some tactics that they can do if bronchiectasis is quite severe. And if you keep having ongoing hemoptysis or coughing up blood. But yes, absolutely, it can be associated with radiation treatment.
Okay, her next question is, how do the long-term heart side effects present from the use of Taxol, adriamycin, and Cytotoxic?
Sure. So of those three chemotherapy drugs, the adriamycin, or also called doxorubicin, is the one that is associated with cardiac toxicity. In general, we think that it's more of a heart failure syndrome that can happen during treatment and sometimes even after. That's why it's very important if you have any kind of cardiac symptoms during or immediately after treatment, it is important to report these to your oncologist. Make sure that you get, an echocardiogram or an ultrasound of the heart. If you have any palpitations or heart fluttering, shortness of breath, fluid retention that aren't normal for you. In terms of what we call coronary artery disease or, blockages within the heart, the vessels that feed the heart, that is more associated with radiation therapy rather than the chemotherapy itself. So, adjuvant radiation and then the anthracycline toxicity are really what we worry about. And it's more around the time for the anthracycline toxicity, it's more around the time of the chemotherapy. Whereas the coronary artery disease risk from radiation therapy, is something that can persist with time. So kind of routine checkups with your primary care doctor, make sure your cholesterol panel is good, and then early reporting of any heart symptoms is important.
Final question is, are there any studies that suggest Arimidex may be beneficial beyond 10 years of use?
Good question. So the exact time that somebody should be on endocrine therapy is still very up for debate. 5 years is essentially the standard. And then there have been some data that suggests that women or men who are at high risk for recurrence may benefit from longer than 5 years. So things that we look at when offering more than 5 years of treatment are risk. So did you have lymph node involvement at the time of diagnosis? Grade 3 tumors, larger than 2 centimeter tumors. And if your breast cancer was high enough risk to get chemotherapy, because some are lower risk and don't need chemotherapy, then those are the types of patients that we generally would offer what we call extended endocrine therapy to. And of course, we have to make sure that the person's tolerating it well. They're not having terrible side effects. They're not having their bone density is not being compromised. Beyond 10 years, we don't really have much, if any, data to suggest that it's beneficial. So I know myself and my colleagues, I don't think we've ever gone beyond 10 years just because you may just be getting toxicity rather than the recurrence risk benefit. So I would say if your oncologist thinks you're high enough risk to go to 10 years and you're tolerating it, it's reasonable. But right now, we just don't have anything to suggest going beyond 10 years.
All right, thank you for for that. So our next question comes from Janet. Hi, Janet. She says, I received Herceptin and had regular heart MUGA scans during treatment. Now that I'm almost 5 years post-treatment, am I still at a higher risk of developing heart failure because I did receive Herceptin, or am I back to normal risk?
It's a good question. We don't have a ton of long-term data kind of in that realm, but what we think is that really the risks of Herceptin or trastuzumab kind of related heart dysfunction they improve with time. So if you're 5 years out, your risk of heart dysfunction is probably close to normal, if not normal. That still means that you have to get kind of routine, cholesterol tests and kind of heart function. You're out of the realm of having to get routine MUGA scans or echoes. But what I would just go back to, if you have any cardiac or heart related symptoms, just make sure you don't take them lightly. But theoretically, your risk will be close to normal, if not normal at this point.
All right, thank you. Next question comes from Shaylee. She says, I just finished up a year of Herceptin in May, and I know that my body is not the same after going through Taxol and radiation and 6 surgeries over the past year, but she has a lot of joint pain and doesn't know if it's from the Arimidex or just that her body has been through hell since May of 2019. So she says, what can she do about her joint pain? And she just turned 43.
So very good question. So Arimidex is notorious for these joint pains or arthralgias that people get. So if I had to blame it on anything, I would blame it on the Arimidex. Other common kind of big issues with Arimidex that can be very, very annoying for people are it can cause muscle cramps or muscle aches. So not just like those joint aches. It can cause joint stiffness. Hot flashes are for sure the most reported side effect with any of like Arimidex, Femara, Aromacin, any of those class of drugs. In terms of what we know about aromatase inhibitor induced joint pains, besides kind of routine, regular exercise and kind of strength training, there's not much. There are some data for acupuncture in this area, actually. And I've had some patients have some success with that. Of course, with the state of, with the pandemic, it may be hard to find an acupuncture place and the price can be prohibitive. What else? Anti-inflammatories, some people get some benefit from it. And then if they're truly debilitating, what I tell people is if there's a bad side effect, often about 50% of the time, if somebody stops Arimidex and goes on one of the other aromatase inhibitors, they'll tolerate it better. We don't know why that is, because they all essentially work the same. They all have the same listed side effect profile. But I think of it like, everybody tolerates certain drugs differently. If every one of us took a Benadryl right now, I bet some of us would get hyper, some of us would get very sleepy, and then some of us would have no problem. So if the joint pains are truly worsening, which we've seen, or to the point where you just can't function very well, maybe talk to your oncologist about trying one of the other ones, just to see if you tolerate it better. There's no harm in that at all. But I would blame your symptoms probably on the Arimidex more than anything else.
Thank you. So now I'm going to go through the questions that Diana, hi Diana, submitted before the conference, or before this session. And I know I sent them to you, Dr. Martin, and you did touch on some of this during your talk, but I want to make sure that we're absolutely addressing her questions. So let's see. She is a survivor of almost 5 years and has been taking Femara 1 a day since March or April of 2016, so quite a while, but she'll be discontinuing that in March of 2021. So her questions may or may not be related to the Femara, but her first one is, I have neuropathy in my feet. It's not too severe, but enough to be uncomfortable, and her feet get quite cold rather often. Will this ever go away, having not subsided in the past 5 years, or will it get worse?
Very good question. So Like I mentioned before, or alluded to, about 60% of women will have some degree of neuropathy soon after or during chemotherapy treatment, particularly if they get treated with Taxol or Taxotere. By about a year after that, or 6 months to a year, that will drop down to about 30%. And then after that, it kind of slowly tapers off. So most of the time, people's neuropathy either improves or resolves, but there is a small percentage of women who are left with neuropathy that never goes away. I would say if you notice continuing improvement, then there's a chance that it will just keep going and potentially resolve. If you feel like it's been stagnant for a while and kind of not really budging, then that may be kind of your new baseline. So we know that most go away, but there's a decent percentage that are left with lingering neuropathy.
Mine hasn't seen. Can you hear me?
Yes.
Okay. Mine, if anything, I think might be getting a little bit worse. It gets worse in the wintertime when I wear heavy, tighter shoes than in the summertime. But sometimes my feet get so cold, I don't know what to do. I put on heavy socks and nothing.
Yes. So two things can certainly make it worse. So cold itself can make people's symptoms of neuropathy worse. And then unfortunately, when you wear tight things, it also reduces the blood flow to the area. And that can also make people's neuropathy flare up a little bit. The other thing, so I feel like a lot of people were told at some point that, if you come out of chemotherapy and you get put on medications like Femara, Arimidex, things like that, there's no way that, those medicines are affecting your neuropathy. Well, I think that was a big overstatement. And a lot of people say that being on those medications actually, for maybe as soon as they start it, cause it to flare. So for now, I would recommend kind of, avoidance of the triggers if you can. Obviously, we're in Cleveland and the cold is coming, and try to wear kind of warm, but maybe not so tight socks or, things like that. If you're having tingling or pain, it may be worth it to try some medication for it, especially if you think it's worsening. And then also ask your oncologist to make sure that, there aren't any other reasons that you could be having worsening neuropathy, such as in your primary care, but doctor may have done this already, but making sure that, you don't have diabetes, or if you do have diabetes, it's under control, and kind of ruling out other causes of neuropathy. But yeah, you're absolutely right. A lot of people note worsening in the cold months. Fortunately, you're coming up on maybe your end of Femara. You said in March. So that would be a good test to see if your symptoms improve once that drug is taken off.
Hopefully.
Go ahead, Diana.
I just blame Femara for everything that's ever happened to me since I had cancer. I get cramps if I reach back to scratch my back, or sometimes when I'm doing my hands will automatically cramp, and I physically have to release it with my other hand. And I don't know if that's from the Femara as well. I went off of it for a while as well. Also, one of my questions was about these hot flashes that I get. I never had a hot flash when I went through menopause. So I'm not sure if that's the right word, but I will just be sitting doing nothing, and I'll have this wash go over my body. I'll feel a little bit dizzy. It takes about 2 seconds and it washes away and I'm fine. And I went off Femara for a little while to see if that kind of went away, but I only went off for 2 weeks.
Mm-hmm.
So I didn't seem to have the episodes while I was off it. So I'm hoping it goes away. The only reason I bring it up was typically it happens when I'm sitting in a chair watching television, or just sitting in a chair or something. But a week or so ago, it happened when I was driving.
Mm.
And that kind of shook me up a little bit. I was fine. I was just about ready to pull over to the side when the wash went through me and it was gone. But I'm just wondering if that's possibly from the Femera. My oncologist said he never heard of that before. So
To me, it sounds like those could be significant hot flash symptoms. I think you want to make sure that you weren't feeling kind of short of breath or palpitations at the same time, or lightheaded or dizzy. And if it was a true
lightheaded
flush,
and dizzy, yeah.
you did feel lightheaded and dizzy?
Yes. But for just seconds, just for a second, and then it's gone.
Okay. All right. So it's still that's still very well could be kind of just like an overwhelming hot flash. And then I'm hopeful that those will just kind of all vanish, once you're off of this medication in March. The vast majority of women have hot flashes on these meds, some of which can be very, very severe. And even if somebody didn't have them when they were when they were going through natural menopause, these can certainly be significant. If they keep happening, or if they worsen or are associated with other symptoms such as palpitations, shortness of breath, blurry vision, that type of thing, you want to make sure you rule out other causes like heart issues, heart arrhythmias or abnormal rhythms, that type of thing. But those to me sound just like very severe hot flashes from what people mentioned to me, and hopefully they'll just go away as soon as you're done.
Thank you. Like I said, I mentioned it to my oncologist, and he said he never heard of it before with the Femera. So I'm glad I had a chance to bring it up here.
Sure. Yeah.
So we are just a little after 1 o'clock. Dr. Martin, you have Diana's additional questions. Would you mind replying to those in an email just to make sure that she gets those addressed as well?
Oh, sure. Absolutely. If anybody has any kind of lingering questions from today, let me just give you my email. It's james.martin@uhhospitals.org. Actually, maybe I can put it in the chat, or Gina, maybe you can type that in the chat.
Yeah.
Please reach out to me if you have any kind of lingering questions, and maybe I can at least point you in the right direction. But yeah, absolutely, I can answer those.
Yeah. So I did drop your email in the chat box. So if anyone wants to copy and paste that, you are welcome to. And thank you for making yourself available for questions after the fact. I did want to, I got the website that I needed to get back up to show you on komen.org. So this is our headquarters website, komen.org. A little different than where our Northeast Ohio website, but they have a page specifically for the late effects of breast cancer treatment. And as you can see, they have some of the common late effects, and you can see everything in blue is a hyperlink. So if you click on that, it will take you to additional information for these specific topics. And then we have some other areas, more rare issues that we talked about today, the cognitive function, lymphedema, numbness, pain, and then rare side effects of specific therapies. And then quality of life after treatment, again, making sure that your quality of life is as good as it can be. And then, of course, even if you are out of treatment, there are still clinical trial opportunities available for people post-treatment. So we can keep enhancing on the discoveries for breast cancer. So if you are interested in participating, there's information there. I will drop the link to this webpage right here in the chat box if you want to take a look at those resources as well. But we are a little over time, so I will just remind everyone that this session was recorded and is live on Facebook. So if you ever need to go back and re-listen, see some of those slides again, they will be available on comenneohio.org probably tomorrow morning. And then, of course, we'll be live on Facebook. And I just want to say, like, after hearing a discussion like this and knowing that most survivors will experience all of these side effects in addition to the treatment that they're going through, I just want to recognize and applaud all of you for your strength and your endurance, for managing all of these side effects and symptoms, and for keeping with your treatment. I know it can be very discouraging and disheartening. So I just want to give you all a shout out for being the strong, fierce women that you are. and for allowing us to, hear your stories and to be able to answer your questions. So I humbly thank you all for participating. So with that, we will give you back the rest of your afternoon. I hope you're able to get outside. It is a little cold, but it's still a really lovely day and probably the last rain-free day we're going to have for a while. So if you can get out, take a walk, get those steps in. Happy Halloween, stay safe and stay healthy. Thank you so much, Dr. Martin, for your time and your expertise. And with that, I hope you all have a good afternoon. Goodbye.
Thank you, Gina and Dr.
Nice to see you.